Welcome to the MS-Perspektive podcast. Perspective with a K, as I'm German. I'm Nele Handwerker, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins.
This podcast is supported by Mid-Mission, a project of the nonprofit Hertie Foundation.
Hello and welcome to episode number 30, ACTRIMS 2023, 10 hot topics and my highlights of day 1. MS Milan 2023 was the 9th joint meeting of the European ECTRIMS and American ACTRIMS Congress. Over 8,600 participants from 108 countries joined and had the chance to listen to 240 faculty members and digest the input from 1,915 abstracts, so quite a number. The 10 hot topics were defined as number 1, MS and EBV, so epstein-barr virus. Number 2, treatment, screening and monitoring. Number 3, MS in the elderly. Number 4, which biomarker and when. Number 5, future therapeutic strategies. Number 6, PIRA and silent progression. So PIRA is for progression independent of relapse activity. Number 7, new technologies for MS patients. Number 8, Prodromic MS. Number 9, HSCT and MS, so hematopoietic stem cell therapy. And number 10, biomarkers of damage and recovery. I will try to pick up some interesting outcomes on most of them during my summary of the 3 days, starting today with the ACTRIMS lecture by Dr. Stephen Hauser and continuing with MS and EBV and MS in the elderly. Let's come to the opening session and ACTRIMS lecture, Multiple Sclerosis, Path to a Cure by Stephen L. Hauser, MD. Stephen L. Hauser is the director of the UCSF Weill Institute of Neurosciences and the professor of the Department of Neurology at the University of California in San Francisco, USA. More and more MS experts go for the strategy of treating MS the earliest possible, and Stephen Hauser agrees with that strategy. The earlier we counteract in the course of multiple sclerosis, the better the long-term results seem to be, and might lead one day to controlling the disease completely, which is very near to a cure. Unfortunately, however, we do not yet know what the initial triggers for MS are, and so far we don't know the specific MS signature we have to look for either. And cure would be dependent on our definition and that stage of disease progression somebody is. For example, in an established MS, treatment would have to target multiple cell types. But take a step back and look at the disease from the very beginning to the end. Stephen Hauser used the metaphor of disease in 3 acts. The first act or phase is the one that comes before the first monitoring, the so-called prodromal phase, in which changes already occur, but about which we do not yet know much. Followed by a mostly relapsing phase with high inflammatory activity, which can now be treated well with immunotherapies. And the third act is the neurodegenerative phase, when you are in the progressive course of MS. From Act 1 to Act 2, the benign autoimmunity becomes pathogenic and starts to destroy tissue in the central nervous system. As we know today, more or less from the beginning of the relapsing course, neurodegeneration already starts. The intensity depends on the severity of the disease and is at the beginning normally very mild, but later increases in intensity while the inflammatory activity decreases. How to detect early signs of MS? We know that MS is not a typical inherited disease, as more than 230 sites in the gene code are associated with increased susceptibility to MS. These gene changes contribute only 19% of the risk of disease, while 81% are due to other causes. Furthermore, certain genetic alterations affect the central nervous system and are responsible for the aggressiveness of the disease. We know from other autoimmune diseases, such as systemic lupus, insulin-dependent diabetes mellitus, and rheumatoid arthritis, that a very specific reaction becomes more non-specific over time and becomes more widespread, leading to the onset of the actual disease. If these changes are detected and treated early, it appears that the onset of the disease can be delayed. At least that is what small studies have shown. MS patients have now been found to have a certain common autoantibody signature that is the same before and after the onset of the disease. However, this profile has only been found in 12 to 15% of patients. The questions that arise are, when does this pattern first appear? Already in the phase of benign changes, or only in the pathogenic preliminary phase of MS? Is this signature only found in high-risk families, or is there a correlation between genes or disease expression? Treatment strategies. Earlier is better. Early acquired impairments often remain permanent and are an indicator of SPMS, so secondary progressive MS. The benefits of early treatment are already being demonstrated in studies of clinical isolated syndrome and radiologically isolated syndrome, as well as in evaluations of registry data on RRMS patients, so relapsing remitting MS patients. Highly effective therapies have been shown to be more protective against later disability. This represents an opportunity to move from suppression of the disease to a cure. Stephen Hauser's speech was very inspiring, and it's nice to know that for the first subset of patients who don't have MS today, this strategy could work. Nevertheless, we have not yet reached this goal. It's a vision, but one that I think is worth sharing. Since Stephen Hauser has been dedicated to multiple sclerosis from the beginning of his scientific career a few decades ago, and has seen the community of scientists and practitioners grow steadily, his vision seems quite realistic to me. However, the timetable remains unclear for the time being. Let's come to hot topic number 1, MS and EBV, implications for management and treatment. So some words on the background. The Epstein-Barr virus, or short EBV, seems to be one of the triggers for MS onset. The virus stays in the body for the rest of the lifetime. The later one gets the first EBV infection, the older one is, the more intense the effects are, and the association with the onset of MS seems to increase. While babies and young children usually take the infection well, in adolescents and young adults, mononucleosis can be quite intense and make you very sick. But please remember that more than 90% worldwide of the population become infected with EBV during their lifetime, and only a fraction of them develop MS. So the infection can by no means be the sole trigger. The EBV infection seems to be an autoimmune potentiator, not only for multiple sclerosis. We don't know yet which potential mechanisms play a role. If it is molecular mimicry, some kind of B-cell transformation, lytic reaction, or a second hit. There's also evidence that resurgent infections of EBV contribute to MS activity and thus have a negative impact on progression. That's why EBV is one defined target of future treatment strategies. What strategies might emerge from the association of EBV infection and MS onset? Number 1, an EBV vaccination followed by exposure to EBV would lead to few or no latently infected B cells. Therefore, reduced likelihood of antibodies or T cells cross-reacting with the nervous system proteins, which ends up in a reduced risk of MS. Number 2, killing EBV-infected cells in patients with MS by infusion of EBV-specific T cells or a therapeutic EBV vaccine for special inhibitors. Most infected B cells would die, and only few latently infected B cells would survive. Reduced antigenic stimulus for EBV-specific antibodies or T cells to recognize nervous system proteins results in reduced MS disease activity. Unfortunately, finding an effective, durable vaccine against MS is not easy. If we get a working EBV vaccine at one point in the future, we would theoretically have to vaccinate babies and then wait 20 years to see if multiple sclerosis and other EBV-triggered diseases occur less. However, the approach of killing EBV-infected T cells might show results more quickly. Now I want to talk very shortly about clinical progression and decision-making. Traditional view of MS progression is active versus progressive, whereas the progressive disease occurs in the absence of relapses, or PIRA, progression independent of relapse activity. Disability accumulation happens due to relapse activity and neurodegeneration, the PIRA, right from the beginning. Relapse activity is driven by the periphery and neurodegeneration by processes happening in the central nervous system itself. Progression independent of disease activity, so PIRA, accounts for half or more of MS patients who experience confirmed disability worsening. Cognitive disability seems to happen at the very beginning of MS onset and can be detected by brain atrophy measurements. Please keep in mind that it depends on the severity of your disease and is not the same for every patient. For example, I get checked every, I think once a year with the MRI on brain atrophy, and everything seems to be fine. And for some other checks. So yeah, please don't be scared. Brain atrophy itself happens already in the phase of CIS, so the clinical isolated syndrome, and keeps ongoing during the relapsing phase and in the progressive phase as well. So brain atrophy and cognitive dysfunction seem to start from the very beginning, often even before motion disability is recognized by the patients. And again, the earlier the treatment with a DMT that stops MS inflammation and maybe has a positive effect on neurodegeneration, the better it seems to slow down progression. Healthy lifestyle should always be taken into account, as it has quite some effects on your body. For measuring MS, it seems a good idea to take brain atrophy and cognitive function into account right from the beginning and not just concentrate on physical disabilities. Let's move over to MS in the elderly. For the topic of MS in the elderly, I choose two abstracts that were presented on the efficacy of MS treatments and the safety of discontinuation. Number one was abstract 68 by Betty M. and others for the MS Milan 2023, evaluating age-dependent efficacy of multiple sclerosis treatments in a real-life cohort. Something on the background. The peak age prevalence of people with MS is shifting towards 55 to 59 years. A meta-analysis of 38 clinical trials published in 2017 showed that DMT's efficacy decreased with age and that after the age of 53, there was no predicted benefit. And that is a topic we have to look into. However, nationwide registry data shows that DMTs continue to be commonly prescribed in people with MS over 60 years. The aim of this abstract was to estimate age-dependent efficacy in terms of disability progression of DMTs, so disease-modifying treatments, in a real-world population of relapsing remitting MS patients. Some details on the methods. It was a multicentric, retrospective cohort study based on prospectively acquired data from the Italian Multiple Sclerosis Register. The main outcome was the confirmed disability worsening defined by an increase of the EDSS score. The higher the EDSS score, the lower points it had to be. You can find the details in the blog article. Determinants of confirmed disability accumulation after 2 years follow-up was assessed using a logistic regression model, including the following covariates. So that means they were matching the people in age, sex, type of onset, if it was monofocal or versus multifocal, disease course, disease duration and EDSS at baseline, number of relapses before baseline, and class of first DMT, so disease-modifying treatment, if it was platform versus high efficacy. And if you do that comparison between groups of more or less equal people, that really helps to give you a more precise outcome of the data. So what were the results? 22,196 people with MS were included. After 2 years follow-up, 3,178 of them, which makes up 14.3%, had a confirmed disability worsening. In the logistic regression analysis, the confirmed disability worsening was associated with an older age at baseline, a multifocal onset, a greater number of relapses before baseline, and platform therapies. So what is the conclusion? In this real-world population of CIS and RRMS patients, older age at DMT start was associated with decreased efficacy in terms of disability worsening prevention. An early treatment with high-efficacy DMTs reduced the risk of disability accrual independently of age. Another abstract was number 99 from Curver et al. For the MS Milan 2023, and the topic was discontinuation of first-line disease-modifying therapy in stable multiple sclerosis, an early terminated multicenter randomized controlled trial. The consequences of discontinuing first-line DMT and MS have not fully been established. So the aim of this trial was to investigate whether first-line DMT can be discontinued in people with stable MS without recurrence of inflammatory disease activity. Let's talk a little bit about the methods. This multicenter randomized controlled non-inferiority trial included 89 people with relapse onset MS aged 18 years or older without any relapse or substantial MRI activity in the previous 5 years. 45 discontinued first-line DMT and 44 continued first-line DMT. The primary outcome was a number of patients with inflammatory disease activity defined as a confirmed relapse or significant MRI activity during follow-up. And this was defined by 3 or more new T2 lesions or 2 or more contrast-enhancing lesions on MRI. Premature discontinuation of the trial was considered if the proportion of patients with inflammatory disease activity in the discontinuation group was higher than in the continuation group, and the 95% confident interval of this difference did not include 0. What were the results? 67.4% were female and 32.6% were male. The mean age at inclusion was 53.5 years, with a standard deviation of 7.8. The median follow-up was 12 months, and it ranged from 7 to 20. The trial was prematurely discontinued because during follow-up, 6 of the 45 participants in the discontinuation group experienced inflammatory disease activity that fulfilled the predefined criteria, versus 0 of the 44 participants in the continuation group. Median time to disease onset was 9 months. Of the 6 participants with inflammatory disease activity, 2 experienced a relapse. The mean age of these 6 patients was 48.7 years, with a standard deviation of 8.6. All restarted DMT, which resulted in stabilization of the disease. In addition to these 6 patients, 5 patients in the discontinuation group and 1 patient in the continuation group experienced radiologically disease activity that was not fulfilling our criteria for significant disease activity. So what is the conclusion? Significant inflammatory disease activity returned in 6 out of 45 participants, which is 13.3%, who discontinued DMT. Based on our pre-planned interim analysis, the trial was discontinued in its current design. So let's give a short summary of that summary of day 1. The speech by Stephen L. Hauser was very inspiring. EBV stays an interesting therapeutic goal, but it seems to be difficult and a long way to come up with trial scenarios that would have an impact on the MS burden. MS in the elderly is a burning topic and will become more crucial year to year as the MS population is aging. I'm glad scientists start looking into this topic more and more. And on the aspect of personal medicine, it would be great to find out how to best treat each individual, when to stop DMTs, and to find effective ways to tackle progression in MS. By the way, next time I will talk about the effect of the menopause on MS progression and what to do and what trials should we set up, the efficacy of different treatment algorithms, including the immune reconstitution therapy and when it's best to use it or start it, and about the main important factors of a healthy lifestyle. And maybe I will pick up a few abstracts on the hot topics. Let's see. So stay tuned and see you next time. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.